from the American Academy of Pediatrics.
The health maintenance visit is always jam-packed with issues we need to address.
How can technology help pediatricians streamline the process?
Screening tools are really important because you can both over pick up and under pick up on problems.
Plus, new research looks at the use of pharmacologic restraints for children with mental health conditions.
There are certain diagnoses that are more likely. Sometimes they're known as externalizing conditions. They're ones that are more associated with the symptoms of agitation, impulse control, decreased communication abilities.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about using technology to increase efficiency in our practices.
Joanna, what feedback do you think we hear most often about topics we cover on the show?
Not sure where you're going with this, but that the podcast is both informative and entertaining.
Well, sure that, but what else?
I think every time we cover a screening or anticipatory guidance topic pediatricians should be addressing at health maintenance exams, people ask how they are supposed to get to all those issues in the limited time pediatricians have in the exam room, because pediatricians are busy.
Yeah, I hear that all the time, and honestly, I struggle with the issue myself. I am a compulsive box checker, and I can find it hard to skip anything that's on the Bright Futures list. On episode 143, Dr. Sue Cressley gave some insights into how to prioritize our limited time, but I need more pointers.
I remember that one. It was great. It was part of our Best Practices subseries of Pediatrics on Call. I think it's time we learn some more best practices about things that have become particularly pressing for children, psychosocial issues, and how to screen for and address them.
Well, we are in luck because today we get to talk to Dr. Barbara Howard. Dr. Howard is a highly acclaimed speaker, president and co-founder of the Chattis Healthcare Software Company, an assistant professor of pediatrics at the Johns Hopkins University School of Medicine, and a developmental behavioral pediatrician. Barbara, welcome.
Hi, I'm so happy to be here. Thank you.
So let's start with the scope of this problem. How often should we expect to walk into a health maintenance exam and encounter a psychosocial issue while we're there?
Well, actually, David, about 25 to 50% of the time, that's actually going to be the main concern that's being brought into the visit. And that data comes from before COVID, so that now it may be even closer to the 50% with some very serious problems, even suicidal ideation. I'm hearing from general pediatricians all the time about how scary and difficult this is and how hard it is to fit into all the other things you have to do in a visit.
You know, I think traditionally pediatricians are used to using screening tools in the clinic to elicit things from patients. But as practices get more technologically advanced, do we have better ways to look for psychosocial issues?
Well, absolutely. And, I have a conflict of interest here because I've actually spent the last 2 decades of my career trying to make it possible for general pediatricians to be comprehensive and efficient at the same time and to use evidence-based ways of picking up on problems. Because if you ask any parent of a 4-year-old if they have any concerns about behavior, 90%, that's real data, say they do. They're very concerned. So
I have a 4-year-old. I understand that.
Right. So screening tools are really important because you can both over pick up and under pick up on problems. And screening tools are designed to try to fit that in so that you're picking up on the most important things and you're not missing it in cases where the parents are not worried. So that's what Chattis is designed to do. And that's what the American Academy of Pediatrics is recommending. So how to make that efficient is part of the problem. So the ability to do questionnaires on paper is actually a limitation due to the front desk. So you know that most of the things in pediatrics are about workflow. And that's even more important now than it ever was because there's so much churn and turnover in staff that you've got to be careful of your staffing and what you're asking them to do. So if you ask the front desk to figure out how to give out more than one paper questionnaire and get it back, somebody has to score it, of course, if you do it on paper, they become overwhelmed and disorganized. So we created an online system. And, electronic health records now have questionnaires built in many cases too. But some of the differences are, what's the level of information you get back and how much of it requires you to be an expert on the tool? So, for example, some electronic records only give you the score. They don't even give you a range. They may or may not give you a pass-fail. So if you're not familiar with that tool, you're not going to know what that means. So it's really important to find a way of making sure that you're getting the rest of the information on how to interpret the result that you're seeing. Not only does it have to be scored accurately, which is often not done with paper, but that you can make an interpretation. By the way, that's also required to bill for a tool. So in other words, just doing a screening tool that might be able to be scored with a CPT code like 96127, there has to be both a score, a validated tool, and an interpretive note. The other thing is, what should you use? Should you use a broad screener or should you use something more specific? Do you have to bring them back a different time to do a more specific tool? Well, if the questionnaires the results can trigger a secondary tool, that can save you both time now, like let's say you decide you want to find out how bad is this anxiety that you pick up on the pediatric symptom checklist. So you say, I'd better do the scared. Well, how are you going to do that in the middle of a visit? So having questionnaires, one triggers the next. Then you have both the initial screen and the refinement. And that can let you understand how important it is, more specifically what you need to do about it.
I love that. And I have to say, having lived through the transition from paper records to electronic health records, I found it revolutionary to be able to do that kind of thing. But then at the same time, there's so much available. Do we know we're doing it right or doing enough or doing too much? Are there metrics that we should be following in our offices and just see, okay, are we doing what we need to do? How do we measure that and evaluate it ourselves?
Well, those are actually several questions in what you just said, David. So one of them is we should be following recommendations. So for example, there's a new recommendation for universal suicide ideation screening at all visits for children age 12 and up. Well, that's actually something that you probably weren't thinking about, because suicide in particular is often a hidden concern, even though most children who then go on to take their lives had seen a medical professional in the last few months. That doesn't mean they brought it up because it's such a difficult thing to talk about and scary for them. And they may actually recognize that it's scary for you too. So you do need to follow recommendations in order to be dealing with these problems. So the recommendations are often age-related, and some of them are problem-related. So for example, there needs to be a validated tool for the diagnosis and monitoring of ADHD symptoms, period. You just can't tell by simply asking the parent, certainly not by asking kids. Kids are kind of like the fish in the water to their own behavioral symptoms, so they're not accurate in doing questionnaires about ADHD. And it's also a definite recommendation to have at least two sources of information. So how do you get information from the teachers? If you put a Vanderbilt in the kid's backpack, expecting it to come back filled out by the teacher, just keep in mind that the kid has ADHD, and sometimes the parent does too. So being able to do this electronically is really important, and there are not too many other ways of contacting teachers securely with FERPA compliance and getting the data back. So first of all, you have to have a plan for which tools you want to use for which kinds of problems. So there's general screeners, there's social determinants of health screeners, there are health risk screeners like substance use, for example, which is definitely a health risk, and they have a different CPT code. And then there are tools that go from primary screening to secondary screening to even diagnostic tools. You don't usually call those screeners, but they are actually can be administered in the same way, including online.
And let's say you identify an issue and it seems unlikely that you have time to manage it during the health maintenance visit. How much can you lean on technology to help you follow up, like AI that talks to patients and tells them how to deal with things like anxiety and depression?
So yes, you should do monitoring questionnaires. And actually, if you're going to take care of children with depression, and who doesn't, frankly, because most depression has to be taken care of in primary care, you have to actually do a follow-up validated tool to assess whether the severity is getting better or not. So that means, for example, PHQ-9s over time or mood and feelings questionnaires over time. So David asked about the metrics. So one metric is, are you screening a large enough proportion of your patients? And that sometimes involves having tools in different languages, frankly, because you're in different cultural settings where you've got people with different languages. So one metric is completed screens. Another metric is, did you follow up? Now, how do you do that? So following up sometimes can be helped by, in your electronic record, set yourself a flag, right? How many do you have waiting on your desktop, David? Flags have to follow up. It's a lot, right? But tracking is one of the most important things, especially for behavioral and psychosocial problems, because you know what? They don't just go away. It's not like a strep throat. So you have a responsibility for management over time. And that means you have to have a tracking system. We did a survey of pediatrics to see what proportion of pediatricians who were screening for autism, for example, had a tracking system for positive cases to find out if they went for the care they were supposed to get. And the answer was less than 10%. Less than 10% of kids who screen positive for autism make it to a diagnostic evaluation. Well, they can't get into services in most places. They can't get them paid for by insurance unless they have some kind of diagnostic evaluation. So there's an example of why tracking is so important, because it's not just you who's stressed out by the diagnosis, the family is too. They may go into denial. They may talk to their partner and the partner says, oh, he's fine. There are all kinds of reasons people may not follow up. So then, it's on us to be the primary medical care home.
And then in terms of tracking, what's an ideal electronic tracking system that's going to help you take care of the many patients that you may screen for psychosocial issues?
Well, it's a good question. When it comes to vaccines, of course, the state has one. When it comes to other systems, the data may go into other electronic health systems, electronic health records, but it doesn't mean that the patient is necessarily reminded.
So, Barbara, you mentioned the number of flags that
Sorry,
I have.
Sorry to upset you.
No, I've been coping with it for a long time now. But I'm wondering about the technology. Are there ways, for example, with referrals, that we can use this technology, leverage it to help us get those completed, close the loop, understand what came back?
I think that most offices have designated a person to be checking on referrals. Mm-hmm. There are other ways of doing that. You may have a way of sending text messages to your patients. There are secure text messaging services. And nowadays, people don't pick up the phone. Have you noticed that? The patients, they're not picking up the phone. So having a texting system is a really good idea to check in with them. And people really appreciate it, by the way. They experience that as you care about me. Actually, for people who have suicidal ideation, automated reminder check-ins by text message that are not a real person those are considered very helpful to the patients. They like it. So a personal one is even better, but you'd have to set something like that up. You can set reminders in your electronic health record to remind you again, I believe. I don't know what percentage of EHRs do that. Does yours?
It does. I don't know if I'm using it to the full possible effect, but it can be done.
So that's an important aspect of using technology to help with care. And that is you may have bought I guess it's not a Cadillac anymore, probably called a Tesla now. You may have bought a Tesla. It doesn't mean you know how to use all the parts of it. And so the initial ramp up for any kind of technology is really important. And getting buy-in from your staff, having somebody be a champion Helps if you give them a title, maybe give them a certificate, maybe they get relieved of some of their other duties in order to champion things and set your system up so it serves you the best it can and is not more trouble than it's worth, because that can be a problem too.
It was actually nice, Barbara, that you said that automated messages can have a real effect on patients who are contemplating suicide or have really big psychosocial issues. I guess the question for a lot of pediatricians, though, is do you lean on things like automated messages? I know a lot of pediatricians also try to use secure chat or apps inside their electronic health record to chat with families so they're not texting on their phone. But, how should they be prioritizing how they're communicating follow-up with patients to be the most impactful so patients will come back and they can access services through the office that they need?
I think that's a very individual question per clinician. So I was just hearing something on the radio the other day about many doctors in emergency sort of situations or who are hospitalists or specialists no longer want to get text messages from their colleagues because they get too many. And they go back to using their beeper. Do you remember your beeper? Do you even have a beeper anymore? So it has to be something that you can manage. And I know that where I get my care, I'm fortunate to be quite healthy, but I got a message from Epic that said, oh, now my chart messages will be charged for. And the reason they'll be charged for is the doctors are getting overwhelmed by messaging. So you have to decide what is actually going to work for you, not just for your patients, because it can become more of a burden if people communicate basically too much or something that's inappropriate and too complicated. You have to prioritize how you're going to handle things so that you can do it safely and not burn out.
I love this. Part of not burning out is for me to get some handle on what actually happens from the time that I walk into the exam room to, if I'm lucky, the time that I walk out. I know with telehealth, we could outsource the entire visit to be remote, but these in-person visits, how much of the work of this visit can I offload into time that I'm not in the room, either before they come in, after they leave, or even just on a tablet before I walk in?
Well, that's part of the reason I do what I do and have comprehensive questionnaires, because you know what? Patients don't like filling out the same questionnaire over and over again on paper, especially when nobody looks at it. And for you as a clinician, having a questionnaire, like a comprehensive health filled out on paper, well, what are you going to do? You have to dictate it or scan it in where you'll never look at it again. So having things in a digital format is really important. But here's what you can count on, and that is patients would rather have a visit where their concerns are addressed than have you spend 80% of the visit asking them if they have a dentist, if they wear their seatbelt, et cetera, et cetera. And actually, those routine questions can be the most of what you spend the visit doing, not getting to the very important and more delicate issues that people sometimes aren't ready to say at the very beginning of the visit. I'm worried about her periods, or I'm concerned she's depressed, or, it looks like he can't read. Those are things that they may not want to bring up right away at the beginning because they want you to be positive and impressed with them. So having a questionnaire is actually a more accurate way of eliciting information as long as you look at it. You've got to look at the results and acknowledge them, but it's easier to say, I see that you said X, than having to elicit the whole story. Then you can focus. Now, the other thing is you'd better have a place in the questionnaire, whether it's online or on paper, that asks what their priorities for the visit are. Because people forget. Did you know that in adult visits, 30% of the time, the main reason the patient came for the visit was never addressed? That's based on research. Now, I hope we do better than that in pediatrics, but they're juggling 3 kids in the office. The kids are screaming because they know they're going to get a shot. It's really possible for people to miss out on asking what they really wanted to do. So having pre-visit questionnaires is very valuable for both having a comprehensive visit and having a visit that addresses the priorities of the patient. By the way, teenagers are a separate issue, and that is the teens will have separate concerns from the parents. And so how to manage that is also very important. And the new 21st Century Cures Act actually is making things more difficult, because what the electronic records have done is they cut the parent off at a certain age. That's the typical way they allow for privacy. Okay, he's 13 now. You don't have to share anything from your parent. Well, I don't know. I've raised several children here, and they weren't ready at 13 to do all of their visit by themselves. So making sure that it's both comprehensive and addresses priorities is the secret.
And we always start out these best practices with the idea that we really want the office visits to be more streamlined and more focused. So before we let you go, Barbara, can you walk us through what you think the structure of a visit should be after you've done all those screeners and your homework before, to try to get the most out of your face-to-face time with the family?
Well, first take at least 1 minute to look at the results of their pre-visit questionnaires. That's the first thing. And then you can set the priorities in your head. You do that anyway when you look at the problem list. So this is the problem list plus the results of the screening tools, right? And then be sure to ask, what do you want to be sure to cover in this visit? It's only respectful to do that. You may not talk about what they want most first, but you want to make sure you cover it sometime. And then, we all have to ease into things as well. So doctors tend to have habits about how they do things. You may have to relook at your habits so that you make sure that you can cover the things that need to be done. So you start off with some general things. I always suggest talking to the kid first, for example. Establish a relationship with them, because if they're not cooperative, you're not going to get what you need from the visit. Plus, it's much more fun that way. That's part of why we're in pediatrics. And then towards the end of the visit, make sure you've covered their priorities, but also ask them, is there anything else you want to bring up? Now, I know it's scary to do that. You got your hand on the doorknob, you've got people waiting, and you're afraid of what they might say. So you don't want to do it at the very, very last second, but making sure you've covered everything and rephrasing the key points that you think got covered is very important. Also, being able to provide educational materials, having that be automated is a big help, but you need to know that people get confused, and having that post-visit summary and have it be personalized to them is really important.
Dr. Howard, speaking of having your hand on the door as you leave the room, is there any final thought that you would like to leave our listeners with?
I know that primary care pediatricians are struggling. I hear from them every day that they're struggling, but you need some support for yourselves too. So making sure that you're talking to the other providers in your office about what they found works and what doesn't work, talking to your staff about that, and talking about the benefits of whatever method you've chosen, and being ready to tweak it. That's part of the MOC4 process of quality improvement in your office, and it's important for screening and technology as it is for other aspects of care.
Thank you so much. To learn more about the topics we discussed today and other best practices, go to aap.org/podcast.
Coming up, we'll look at the use of pharmacologic restraints for children hospitalized with mental health diagnoses.
Joanna, you know how hard it's been for me as an inpatient hospitalist, taking care of children with mental health disorders. The hospital I work at doesn't have a formal psychiatric unit for children, so they board in the ED, or on one occasion, get admitted to the pediatric floor. They might stay with us for months awaiting a bed.
So how do you ensure that they get the proper psychiatric care that they need?
That's what makes the care so hard. We use telehealth, but I'm not sure we're providing the best care when these children aren't on a more specialized service or ward.
Well, this is where we need to turn to the Journal of Pediatrics to start to piece together how mental health care is being delivered to kids and how we can improve on it. There's this one article that might be especially interesting to you, David. It's entitled Pharmacologic Restraint Use During Mental Health Admission to Children's Hospitals.
Ooh, that is such a sensitive and complicated topic. Let's invite the first author, Dr. Benjamin Masserano, to the show.
Dr. Masserano is a hospitalist medicine fellow at University of Texas Southwestern at Children's Health in Dallas, Texas. Dr. Masserano, welcome to the show.
Thanks for having me.
Ben, I'm sure our listeners are familiar with the increasing need for mental health care in this country, but can you tell us a little more about the mental health hospital admissions that we see for children?
Yeah, David, the prevalence of pediatric mental health disorders has been increasing over the past 2 decades. Like you said, in the setting of limited outpatient and inpatient mental health resources, this has led to an increase in the amount of kids in mental health crisis being admitted to acute care children's hospitals. To discuss the prevalence of mental health admissions, I'll have to go back to a study by Dr. Zima and colleagues in 2016 that looked at the past decade of mental health admissions in comparison to total admissions. They found that 5% of those admissions involved a primary psychiatric indication. And since that time, studies indicate that this rate has increased, especially during the COVID-19 pandemic.
And for children who need to be restrained in the hospital because of a mental health issue, there are different types of restraints we can use in the inpatient setting. And your paper focuses on pharmacologic restraints. Can you tell us how you defined what a pharmacologic restraint is?
Yeah, well, first, I think it's important to note that the term pharmacologic restraint is widely used in the medical literature, but it's controversial for some psychiatrists. This is because it doesn't distinguish between the treatment of a psychiatric illness and the legal definition of restricting a patient's behavior. So in the broadest possible sense, a pharmacologic restraint includes any medicine used to treat acute agitation and rapidly return a patient to a safe state. Now, this includes medicines taken by mouth or by injection, which most commonly include classes like antihistamine, benzodiazepines, and antipsychotic medications. Now, in our study, we used a narrow definition of pharmacologic restraint to be as specific as possible for the management of severe agitation. That meant that we only included antipsychotic medications in their short-acting form given via injection. We excluded antihistamines, benzodiazepines, and some antipsychotic medications with other common medical indications apart from agitation management.
And when would a pediatrician need to use pharmacologic restraints on, for example, a hospitalized or a patient in the emergency department?
So when describing their use, I think it's important to understand the multiple steps that are involved in preventing the situation from occurring. So at our children's hospital, we make sure that children at risk of agitation are placed in safe rooms with all potential harmful objects removed. Staff are trained in de-escalation techniques. The psychiatry and hospital medicine teams collaborate with the family to make a clear agitation plan. And then only if safety concerns arise, we activate our behavioral emergency response team with medical and psychiatric experts. And if de-escalation fails, then we think about using these types of medications.
And are there certain pediatric mental health diagnoses that are more likely to get these pharmacologic restraints in hospital?
Yeah, there are certain diagnoses that are more likely. Sometimes they're known as externalizing conditions. They're ones that are more associated with the symptoms of agitation, impulse control, decreased communication abilities, and these can all lead to situations that necessitate pharmacologic restraint. So we looked at the amount of pharmacologic restraint by diagnosis, and our top 3 diagnoses included autism, substance-related disorders, and disruptive disorders. And I want to highlight autism because we found that 8% of autism admissions involved pharmacologic restraint use.
The goal of your study was to look at the use of pharmacologic restraint in mental health admissions to children's hospitals. Where did you go to find reliable data on this topic?
So we went to the Pediatric Health Information System database. This collects data from 49 different children's hospitals across the United States. It's clinical and billing data. And so our data came from 43 of those children's hospitals, which had the best data for the study. It included children 5 to 17 years old, and we only included children with a primary discharge diagnosis of a psychiatric condition.
And I have 2 separate questions for you, Ben, but I think they're related. So in terms of patient demographics, what type of pediatric patient was most likely to need a mental health hospital admission? And was that the patient that was also exposed to the most use of pharmacologic restraint?
Yeah, so as part of this study, we looked into those sociodemographic characteristics. When talking about the most likely to have a mental health hospitalization, those would be non-Hispanic white patients, those would be overwhelmingly female, and those would be older patients between 16 and 19 years old. In looking at those that are more likely to get pharmacologic restraint, that looked very different. So disproportionate rates of pharmacologic restraint were found in the younger age group, 5 to 8. They were found in non-Hispanic Black patients. They were found in male patients. And then in looking at some of the economic qualities, they were found more highly in those with public insurance and those in the lowest group of the Child Opportunity Index, which measures levels of opportunities and resources by zip code.
So, Ben, any idea why we're seeing this disparity of who's getting admitted and who's getting the pharmacologic restraint?
Well, based on our study, I can't say exactly why this is occurring. I will say that in other national studies of emergency department patients, we see some of the same patterns. And all of it is suggesting a pattern of racial and socioeconomic disparity in our mental health care in this country.
Overall, Ben, we know that we're seeing increased mental health admissions for children. Does that account for the increase in the use of pharmacologic restraint, or is it disproportionate?
So our study findings indicate that during this study period between 2016 and 2021, the rate of pharmacologic restraint use remained stable. However, the incidence of pharmacologic restraint use increased by 141%. So basically over doubled. And this was attributed to an increase in hospital days for these patients.
So, Ben, what I hear you saying is that all of the increase we saw in pharmacologic restraint was attributable to increase in days of psychiatric hospitalization, not a trend that there are more restraints compared to the number of days.
Those were our overall measures. We did also look at trends in restraint by specific diagnosis, and there were a number of diagnoses that showed increases in the rates of restraint use. Those diagnoses included disruptive disorders that increased by 40%. They included bipolar disorders that doubled. Eating disorders increased by 2.5%, and then somatic disorders increased by a whopping 4.5%.
This has been so fascinating, if not a little sobering. Do you have any last takeaways for our listeners before they go read this paper about pharmacologic restraints?
Well, with this paper, we wanted to highlight the current landscape of mental health care in the United States and show people that these admissions are increasing and this use of pharmacologic restraint is increasing in kind. I think it's important for our inpatient providers to take a look at the practices within their hospital, because there are a ton of people doing amazing work at improving our ability to care for these patients. And I hope this study can help guide some of those efforts.
I certainly hope so, too. And Dr. Ben Masserano, thank you so much for joining us today.
Thank you for having me.
To read the paper, Pharmacologic Restraint Used During Mental Health Admission to Children's Hospitals, go to our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. And guess what, David? Last week, you made the Say Ah all about me, so I am turning the tables. You have something pretty special to share, right? You're running for office.
Yeah, okay, that's true. I am. I'm running for the North Carolina State Senate, and I'm just so excited to have a chance to put all this advocacy into action. And I cannot express specifically how grateful I am to a couple of our colleagues, Dr. Annie Andrews and Dr. Richard Pan, who gave me amazing advice and were critical in helping me make this decision, and all the others who have worked to take care of children through public service.
Of course, advocacy has always been a part of pediatrics, and so has public service. What motivated you?
You know, it's the same thing that's been motivating me ever since I began my involvement with the North Carolina Pediatric Society and the American Academy of Pediatrics in 2009. I see problems, and I know you do too, in the hospital, in the exam room, that we cannot fix there. We are putting Band-Aids on these issues when the real solutions are policy solutions, right? And I can't think of a better place to get in and fix the policy and stop putting on Band-Aids than to actually get into the legislature and stop being a Monday morning quarterback and start, get the pads and the helmet on and play the game.
I think, David, that's a great reason why pediatricians might want to take their advocacy beyond the clinic walls. And what changes would you like to make?
Immediately in North Carolina, the environmental provisions are really important to me. We've had air quality questions and very serious water quality problems right here. Education is huge. We need to ensure that families get a living wage, that our infrastructure is up to par. I mean, we have had so many episodes on this podcast about the sorts of supports that families need to successfully raise kids who are thriving, and all of it comes back to policy. So let's go do that.
Well, David, I wish you good luck, and I'm curious to see how the campaign goes.
Yeah, so am I. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about food contamination.
We'll talk to Dr. Kevin Osterhout about lead in applesauce and other exposures to heavy metals. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.